I'm Will Olsner. I'm a third-year medical student working in the Schoenecker lab, and this is some of our research and philosophy into the acute phase response. As clinicians, we take care of patients. When our body gets injured, we need to heal. The acute phase response initiates that healing process. The acute phase response is how the body responds to tissue damage. It is an endocrine system between damaged cells and the liver. Let's take a muscle skeletal tissue, for example, a muscle. Damage to this muscle causes dysfunction, bleeding, and an increased risk for infection. As a consequence, the body initiates an incredibly orchestrated reaction termed the acute phase response. During this response, factors released from the damaged tissues immediately travel to the liver through the venous vasculature. Of those factors, interleukin-6 is the most robust effector cytokine released. TNF-alpha and IL-1 beta modify IL-6. And together, those cytokines stimulate the immediate positive and negative regulation of over 1,000 hepatic genes. Those genes are responsible for the acute phase reactants. These reactants have multiple functions, but their primary function is in augmenting the clotting and inflammatory cascades to stop bleeding, to prevent infection. Their secondary function is in tissue repair, thus ending tissue dysfunction. Of the hundreds of proteins affected by the acute phase response, we'll examine a few. The APR increases the systemic level of specific proteins, including CRP and fibrinogen. CRP is a systemic marker of inflammation and increases macrophage activity. Fibrinogen is an integral factor in coagulation and necessary for hemostasis. The APR also results in the downregulation of proteins routinely produced by the liver, including albumin and transferrin. Essentially, the liver prioritizes the production of proteins to maintain hemostasis and promote tissue repair over proteins that are normally produced in the liver during the non-injured state. We are currently in the process of determining the acute phase response following different injuries and pathologies at different ages. So far, we and others have determined that children have a robust yet succinct acute phase response. Adults have a similar but often more exuberant and persistent response. And patients with comorbidities such as diabetes display the most disorganized and often quite prolonged responses. Oftentimes, the acute phase response does not resolve. Importantly, through this research, we have found that for efficient healing, this response must be on and off, like a child's, or the patient suffers the consequences of a prolonged acute phase response, leading to thrombosis, hyperinflammatory states, and poor wound healing. Similar complications from this response are observed in patients with ever-healing wounds, including those with cancer or infection. Mr. An and Mr. Benvenuti will talk more about infection next week. Thus, clinically, we have two objectives in studying the acute phase response. First, to predict post-operative complications, allowing for pharmacological intervention, and two, to determine how to harness the power of the acute phase reactants to improve healing and avoid complications of a persistent or exuberant acute phase response. To recap, the acute phase response is an endocrine system between damaged tissues and the liver. It is essential for normal wound healing, but if prolonged or too robust, it can lead to life-threatening coagulopathies. In order to prevent and intercede in these life-threatening coagulopathies, we must first know the normal acute phase response. To identify the normal response, we looked at the acute phase response following total knee arthroplasty. Here is CRP following a TKA, indicated by the dotted line. CRP has a quick on and off. We found that it peaks around postoperative day 2, and it is resolved by the 2-week visit. CRP is a short half-life acute phase reactant. Fibrinogen has a gradual increase and a longer peak, occurring sometime between discharge and the 2-week visit. Resolution occurs at 6 weeks. Fibrinogen is a long half-life acute phase reactant. This is our acute phase response profile for an acute injury with resolution. But how does the timing of these acute phase reactants correlate to the timing of how the body heals? The cumulative actions of hundreds of acute phase reactants can be summed up in 2 phases: hemostasis and repair. The first phase is rapid and immediately follows injury. Recall Mr. Baker's talk on coagulation, how the activation of the coagulation system allows for hemostasis to prevent loss of life. The second phase is prolonged and is responsible for the actions of coagulation. Recall Mr. Wallace's talk on the wood chipper of fibrinolysis, how the breakdown of fibrin by plasmin is essential for wound healing. To prevent loss of life, hemorrhage must be stopped. Fibrinogen is rapidly cleaved by thrombin, the spark in the jet engine of coagulation, to yield fibrin. Fibrin forms a meshwork, and it is systematically laid down, stopping the flow of blood. This creates a temporary, provisional compartment to regain function. Phase 2 is repair of the damaged tissue. Fibrinogen is rapidly cleaved by plasmin, the wood chipper of fibrinolysis, to produce D-dimer, a fibrin split product. Plasmin activity is highly regulated by UPA and TPA. Once activated, plasmin systematically clears the fibrin meshwork as a necessary step of tissue regeneration, a component of organized regeneration. Coming back to our APR time course, how do changes in D-dimer levels correlate with changes in CRP and fibrinogen? What we found is that there is a small peak immediately post-op, which returns to baseline. There's a gradual increase, with D-dimer levels peaking between the 2-week and the 6-week visit. During the 6 weeks of the study, D-dimer was unresolved. To recap, the first phase of the acute phase response is hemostasis. Fibrinogen is activated by the coagulation system, specifically thrombin, to yield fibrin. Fibrin forms a meshwork. The second phase is repair. It's removal of that fibrin meshwork. Fibrin is cleaved by plasmin to yield D-dimer, a fibrin split product. What happens when your acute phase response is too robust? What happens when your acute phase response is too little? Coming back to our diagram of the acute phase response, we can see that the liver is integral in generating the acute phase reactants. As such, injury to the liver can neuter the acute phase response. Cirrhosis is just one clinical example of a blunted acute phase response. We will modify this diagram to fit the clinical scenario of cirrhosis. The 3 leading causes of cirrhosis, chronic hepatitis C and B, and alcoholism, ultimately lead to impaired hepatic function. As the liver is the organ that generates the acute phase response, decreased function leads to decreased acute phase reactants. This leads to a lower systemic level of CRP and fibrinogen. Because of the impaired hepatic function from cirrhosis, there will be an overall drop in protein production by the liver. This also applies to albumin and transferrin. Because the body cannot mount a complete acute phase response, injured tissue has impaired healing, resulting in an increased IL-6 production from prolonged injury. How will the time course be affected? These are the levels in a healthy patient. Let's examine CRP. In a cirrhotic, CRP levels drop because CRP is produced by the liver. Fibrinogen is also produced by the liver, and in the setting of cirrhosis, there is a blunted response. Interestingly, cirrhotics have increased fibrinolysis and fibrin split products, such as D-dimer. This is a blunted and skewed acute phase response. Low CRP, low fibrinogen, high D-dimer. This is the cirrhotic response. Coming back to our anatomical effects of the acute phase response, let's take a look at how hemostasis is modulated in cirrhosis. Fibrinogen, one of our acute phase reactants, is activated by thrombin in the coagulation engine to yield a fibrin clot. In cirrhosis, the liver has decreased production of clotting factors and a decreased fibrinogen. The combination of these two components results in decreased fibrin deposition. To further complicate hemostasis, there is also platelet dysfunction. Ultimately, this leads to ineffective hemostasis, resulting in increased bleeding. Furthermore, the lack of compartmentalization leads to an increased risk for infection. The clinical scenario of polytrauma is one example of a robust acute phase response. This is the acute phase response for a minor injury. In the case of polytrauma, there is significantly more tissue injury, with significantly more cells releasing IL-6. As a result, the liver undergoes a more robust acute phase response, leading to a dramatic increase in CRP and fibrinogen, as well as a decrease in albumin and transferrin. This is the time course of the acute phase response for a minor injury. For this minor injury, there is no complications. But as the degree of tissue injury increases, the acute phase response increases, increasing the risk for coagulopathies and severe complications. Coming back to the anatomical effects, let's take a look at the first phase, hemostasis, and see how it is modulated in polytrauma. Fibrinogen, one of our acute phase reactants, is activated by thrombin in the coagulation engine to yield a fibrin clot. With a too robust acute phase response, more fibrinogen and more activation leads to more fibrin deposition and more complications. To recap, one clinical example of a blunted acute phase response is the cirrhotic. In the setting of liver disease and cirrhosis, decreased fibrinogen and decreased coagulation factors results in decreased fibrin deposition, thus resulting in ineffective hemostasis, increased risk for bleeds, and increased risk for infections. One example of an exuberant acute phase response is polytrauma, resulting in increased fibrinogen and increased activation of the coagulation system, resulting in a hypercoagulable state and a high risk for coagulopathies. There is a balance between having a blunted acute phase response and having a too exuberant response. In taking care of patients, can we use this information to find a sweet spot to maximize wound healing while minimizing complications? To answer this overarching hypothesis, we must first answer the specific hypothesis: do patients respond to the same injury in the same way? To answer this specific question, we will look at 160 patients undergoing total knee arthroplasty. As we grow our population of healthy patients, we find that trends emerge. And what we found was that these trends were both predictable and consistent. And from these trends, we were able to define what is the normal response. For our healthy population, we found that CRP peaked on day 2 and was resolved by 2 weeks. Fibrinogen peaked between the inpatient period and 2 weeks and was resolved by 6 weeks, and D-dimer was not resolved within our 6-week time frame. Is the acute phase response the same for all surgeries? Do total knees fare worse than total hips? For a healthy population, we define this as the normal response to a TKA. When we compare this time course with that of a total hip, we find that there is a significantly reduced CRP and fibrinogen levels post-op. Both operations have different damage and a different acute phase response profile. Essentially, a total hip does not equal a total knee. This leads us to an essential question. Is there a critical anatomical location that, if injured, signals for a more robust acute phase response? To test this hypothesis, we will compare total hips, PAOs, and intertrocks. We will now use the THA profile as a baseline to compare it to the other surgeries. Observed in the wards, patients undergoing a PAO ambulate sooner and recover faster. How does a PAO compare to a total hip? From preliminary data, there is a dramatic drop in postoperative acute phase reactants in PAOs compared to THAs. A PAO is less inflammatory. How do intertrocks compare? We see that intertrocks have an elevated acute phase response that exceeds that of a total hip. If we add PAOs back into the comparison, we can see that both total hips and intertrocks have a far greater acute phase response than PAOs. If we examine the area underneath the curve for PAOs and intertrocks, we can see that intertrocks have a far more exuberant acute phase response. Thus, we propose that the femur has a much greater capacity to signal inflammation and elevate an acute phase response. Perhaps the general surgery axiom, "Don't mess with the pancreas," should also be applied to the femur. These two acute phase responses are not equal, and as such, their risk for coagulopathies are not the same. A more exuberant acute phase response has a higher risk of thromboembolic events. Let's examine the duration of elevated CRP. In intertrocks, the duration is longer than that of PAOs. As such, perhaps PAOs should receive a shorter duration of prophylaxis than intertrocks to maximize wound healing and to minimize complications from prophylaxis during critical periods. To recap, different surgeries have different acute phase response profiles. Different anatomical locations have different capacities to signal inflammation and to signal an acute phase response. The femur has a strong inflammatory signal. Perhaps we can use the knowledge of the magnitude and the duration of the acute phase response to direct the duration of prophylaxis in order to maximize wound healing and minimize complications during critical time periods. We just saw that different surgeries produce different acute phase responses. Where this becomes more complicated is when we have multiple injuries. This is where the field of damage control orthopedics has taught us how to optimize the timing of surgical interventions in order to reduce complications. Let's come back to our model of polytrauma. Knowing that surgeries produce different degrees of tissue injury, we can see that the IL-6 produced from the surgical intervention can add to the IL-6 produced from the trauma, resulting in a more robust acute phase response. Let's take IL-6 for example. There is a critical threshold of IL-6 that predicts multiple organ dysfunction syndrome with an 85% accuracy. Furthermore, there is a higher threshold at which mortality is predicted. This is the IL-6 peak caused by the initial trauma. This is the first hit. The second hit occurs through surgical intervention. If these two hits occur too succinctly before resolution of the initial trauma, then they are additive and can lead to iatrogenic complications. This is the two-hit hypothesis, where the first hit is the initial trauma and the second hit is the surgical trauma. However, if we come back to the initial trauma and instead stabilize the patient and wait for some resolution of IL-6 and the initial degree of tissue injury, then we can stagger the effects of the two hits, making them separate and not additive. If we compare the area underneath the curve for the two curves, the red curve being the immediate intervention and the blue curve being the delayed intervention, we can see that they have the same area underneath the curve because they have the same damage, same initial trauma, same surgical intervention. However, max CRP for the delayed intervention never reaches the critical threshold. Thus, we use knowledge of the acute phase response to optimize timing of interventions to prevent complications. Take-home message. The acute phase response is an endocrine system between damaged cells and the liver. It is essential for normal wound healing, but if too robust, it can lead to life-threatening coagulopathies. A blunted response can lead to poor wound healing, increased risk for infection and bleeding. An exuberant response can lead to thromboembolic events. Different surgeries have different acute phase response profiles. Perhaps we can use the knowledge of the profiles to direct the duration of prophylaxis in order to maximize wound healing while minimizing complications of therapy. Furthermore, the field of damage control orthopedics has showed us that we can use the timing of surgical interventions to minimize the risk of creating a more exuberant acute phase response. Thank you.